Okay, I'm gonna do the maternal child book, um, pages 334 to 349, Preeclampsia. So I'm gonna start with basically just chapter 14 here. Providing safe and effective care for the high-risk patient requires a joint effort from all members of the healthcare team, with each member contributing unique skills and talents to provide optimum outcomes for mother and infant. This chapter discusses a wide range of disorders that did not exist before pregnancy, all of which have at least one thing in common: their occurrence in pregnancy puts the woman and fetus at risk. Hypertension in pregnancy, hyperemesis, gravidarum, hemorrhagic complications, and early and late pregnancy, surgery during pregnancy, and trauma are discussed. So hypertension in pregnancy. Significance and incidence. Hypertensive disorders complicate 6% to 8% of all pregnancies and are the most common medical complication of pregnancy. The rate of pregnancy-related hypertension has risen steadily by approximately 30% to 40% since 1990 for all ages, races, and ethnic groups, to the current rate of 39.9 per 1,000 live births. The highest since the data were first reported. Rates for chronic hypertension have increased 10.4 per 1,000 live births, whereas the rate for eclampsia has declined 4 per 1,000 live births. Age distribution remains U-shaped, with women younger than age 20 and older than 40 having the highest rates of occurrence for pregnancy-related hypertension. However, rates of chronic hypertension in mothers age 40 and older are 8 times higher than those under age 20, 29.2 compared to 3.7 per 1,000 live births. Maternal race also influences the rate of pregnancy-associated hypertension, with the highest rates seen in non-Hispanic black women and non-Hispanic white women. Hispanic women have an intermediate rate. Morbidity and mortality. Preeclampsia is the second leading cause of maternal morbidity and mortality in the U.S. Maternal complications of preeclampsia include renal and liver failure, HELP, H-E-L-L-P syndrome, and cerebral edema and seizures. Maternal deaths are associated with preeclampsia primarily result from complications of hepatic rupture, abruptio placentae, and eclampsia. Preeclampsia usually occurs after the second trimester of pregnancy, early with hydatidiform mole and hydrops, and contributes to intrauterine fetal death and perinatal mortality. Causes of perinatal death related to preeclampsia are uteroplacental insufficiency and abruptio placentae, which lead to intrauterine death, preterm birth, and low birth weight. Eclampsia, characterized by seizures from profound cerebral effects of preeclampsia, is the major maternal risk. As a rule, maternal and perinatal morbidity and mortality rates are highest when eclampsia is seen early in gestation, before 28 weeks. Maternal age is greater than 25 years. The woman is multigravida, and chronic hypertension or renal disease is present. The fetus of the eclamptic woman is at increased risk from abruptio placentae, preterm birth, intrauterine growth restriction, and acute hypoxia. Classification. The classification system most commonly used in the United States is based on reports from the American College of Obstetricians and Gynecologists, ACOG, and the National High Blood Pressure Education Program, NHBPEP, Working Group on High Blood Pressure in Pregnancy. The classification system is summarized in Table 14.1. Gestational hypertension. Gestational hypertension is the onset of hypertension during pregnancy or in the first 24 hours after birth without other signs or symptoms of preeclampsia and without pre-existing hypertension. The blood pressure BP returns to normal within 6 weeks of birth. Gestational hypertension is a nonspecific term that replaces the term pregnancy-induced hypertension. Gestational hypertension is a provisional diagnosis that includes women with preeclampsia who do not yet have proteinuria and women who do not have preeclampsia. Preeclampsia. Preeclampsia is a pregnancy-specific syndrome in which hypertension develops after 20 weeks of gestation in a previously normotensive woman. It is a multi-system vasospastic disease process of reduced organ perfusion characterized by the presence of hypertension and proteinuria with a clinical continuum from mild to severe. Table 14.2. With mild preeclampsia, hypertension, systolic BP below 160 mmHg and diastolic BP below 110 mmHg. The proteinuria are present, and there is no evidence of organ dysfunction. Hypertension, whether gestational or chronic, is defined as a systolic BP greater than 140, a diastolic greater than 90 Hg. Or a mean arterial pressure greater than 105, recorded on 2 separate occasions at least 4 hours apart. Elevations over pre-pregnancy values are no longer considered diagnostic for preeclampsia. However, women who demonstrate an increase in BP of 30 mmHg systolic or 15 diastolic warrant close observation if the BP elevation occurs with proteinuria and hyperuricemia, or uric acid of 6 milligrams per deciliter or more. Uric acid levels may be higher than 6 milligrams per deciliter in normotensive women with multifetal gestation, thus it is not diagnostic for preeclampsia. Proteinuria is defined as a concentration of 30 milligrams per deciliter or more in at least 2 random urine specimens collected at least 6 hours apart with no evidence of urinary tract infection. In a 24-hour specimen, proteinuria is defined as a concentration of 300 milligrams per liter or greater per 24 hours, boxed 14.1. The diagnosis of proteinuria should be based on a 24-hour urine collection of a timed collection corrected for creatinine excretion if a 24-hour specimen is not feasible. So classification, table 14.1, classifications of hypertensive states of pregnancy. Gestational hypertension. Description. Blood pressure elevation detected first time after mid-pregnancy without proteinuria, previously known as pregnancy-induced hypertension. Transient hypertension. Gestational hypertension with no signs of preeclampsia present at the time of birth, and hypertension resolves by 12 weeks after birth. This is a retrospective diagnosis. Preeclampsia. Pregnancy-specific syndrome that usually occurs after 20 weeks of gestation and is determined by gestational hypertension plus proteinuria. Eclampsia would be the occurrence of seizures in a woman with preeclampsia that cannot be attributed to other causes. Chronic hypertension. Hypertension that is present and observable before pregnancy or that is diagnosed before week 20 of gestation. Preeclampsia is superimposed on chronic hypertension. That would be chronic hypertension with new proteinuria or an exacerbation of hypertension previously well controlled, or proteinuria, thrombocytopenia, or increases in hepatocellular enzymes. Okay. Severe preeclampsia. Severe preeclampsia is the presence of a systolic BP of greater than 160 or a diastolic of at least 110 and proteinuria of 5 Hg or more per 24-hour specimen. Other signs and symptoms associated with severe preeclampsia as altered level preeclampsia include the following: oliguria, cerebral disturbances such as altered level of consciousness, confusion or headache, visual disturbances such as scotomata or blurred vision, hepatic involvement including epigastric pain, right upper quadrant pain, impaired liver function or elevated liver enzymes, thrombocytopenia with a platelet count less than 100,000 per mm cubed, and hemolytic anemia, pulmonary edema, and fetal growth restriction. Eclampsia. Eclampsia is the onset of seizure activity or coma in the woman diagnosed with preeclampsia with no history of pre-existing pathology that can result in seizure activity. The initial presentation of eclampsia varies, with 1/3 of the women developing eclampsia during the pregnancy, 1/3 during labor, and 1/3 within 72 hours after giving birth. Chronic hypertension. Chronic hypertension is defined as a hypertension present within the pregnancy or diagnosed before 20 weeks of gestation. Most women experience uncomplicated pregnancies. However, there is an increase of poor fetal growth and fetal demise. Preconception counseling is recommended for women with chronic hypertension. Chronic hypertension with superimposed preeclampsia. Approximately 25% of women with chronic hypertension develop preeclampsia or eclampsia. This disorder is associated with severe maternal and fetal complications. Chronic hypertension with superimposed preeclampsia is defined in the presence of the following findings: hypertension before 20 weeks of gestation with new onset proteinuria, both hypertension and proteinuria before 24 weeks of gestation, sudden increase in proteinuria, a sudden increase in BP in women whose hypertension has previously been well controlled, thrombocytopenia, elevated liver enzymes. Preeclampsia etiology. Preeclampsia is a condition unique to human pregnancy. Signs and symptoms develop only during pregnancy and disappear soon after birth of the fetus and placenta. The ultimate cause remains unknown. Preeclampsia is seen more frequently in prima gravidas. Age distribution remains U-shaped, with women younger than 20 and older than 40 having the highest rates of occurrence. Certain risk factors are associated with the development of the condition, such as nulliparity, family history, or preeclampsia, multi-gestation, obesity, and chronic medical disorders. Some studies have shown an increased risk for preeclampsia in multiparous women with new partners for subsequent pregnancies. There appears to be a paternal factor involved, i.e. men who fathered one pregnancy complicated by preeclampsia were nearly twice as likely to father a preeclamptic pregnancy in a different woman. Include various possibilities: abnormal prostaglandin action, endothelial cell dysfunction, coagulation abnormalities, vasoconstrictor hormone, and dietary deficiencies or excesses. Immunologic factors and genetic disposition may also play an important role. Animal studies have suggested that abnormalities of the placenta are the cause of preeclampsia. The trophoblast cells of the placenta usually have to alter the spiral arteries in the uterus to accommodate increased blood flow. Instead, the vessels seen in preeclampsia are abnormally thick, walled, and muscular, and have higher resistance. The condition also results in a distinctive lesion called acute atherosis, and there are increased numbers of placental infarcts. Placental perfusion is decreased, resulting in hypoxia. This causes several pathophysiologic abnormalities, especially endothelial damage. Thus, many of the pathophysiologic changes of preeclampsia occur before clinical symptoms develop. Since the etiology of preeclampsia is unknown, various clinical trials have attempted to correct theoretic abnormalities present in preeclampsia as a means of preventing preeclampsia. Some methods used to prevent preeclampsia are listed in box 14.3. Methods to prevent preeclampsia: high protein and low salt diet, nutrition, supplementation or protein, calcium, magnesium, zinc, fish and evening primrose oil, antihypertensive drugs including diuretics, antithrombotic agents, low dose aspirin, dipyridamole, heparin, and vitamins E and C. Here's box 14. For normal physiologic adaptations to pregnancy, cardiovascular would be high blood volume, plasma volume expansion greater than red cell mass expansion, leading to physiologic anemia of pregnancy. These are normal. And then a lower total peripheral resistance, decreases in blood pressure readings and MAP. Then an increase in cardiac output resulting from increased blood volume, slight increase in heart rate to compensate for peripheral relaxation. Increase in oxygen consumption, physiologic edema related to lower plasma colloid osmotic pressure and higher venous capillary hydrostatic pressure. Hematologic would be higher clotting factors predisposing to DIC and clotting, lower serum albumin resulting in decreases in colloid osmotic pressure predisposing to pulmonary edema. Renal would be high increase in renal plasma flow and glomerular filtration rate. Endocrine would be increase estrogen production resulting in increase in renin-angiotensin 2 aldosterone secretion, increase in progesterone production blocking aldosterone effect, slight decrease in sodium. Okay. So the estrogen production raises the renin-angiotensin aldosterone secretion, but the progesterone production blocks aldosterone effect. And then it also has an increase in vasodilator prostaglandins, resulting in resistance to angiotensin 2, a slight lowering of blood pressure. So, pathophysiology. Preeclampsia progresses along a continuum from mild disease to severe preeclampsia. Hell Lp syndrome or eclampsia, the pathophysiology of preeclampsia, reflects alterations in the normal adaptations of pregnancy. Normal physiologic adaptations to pregnancy include increased blood plasma volume, vasodilation, decreased systemic vascular resistance, elevated cardiac output, and decreased colloid osmotic pressure. The main pathogenic factor is not an increase in BP, but poor perfusion as a result of vasospasm. Arteriolar vasospasm diminishes the diameter of blood vessels, which impedes blood flow to all organs and increases BP. Okay, arterial vasospasm diminishes the diameter of blood vessels, which impedes blood flow to all organs and increases BP. Gotcha. Function in organs such as the placenta, kidneys, liver, and brain is depressed by as much as 40% to 60%. The pathophysiologic sequelae are shown in figure 14.2. Preeclampsia contributes significantly to restrictions of fetal growth and incidence of placental abruption. Impaired placental perfusion leads to early degenerative aging of the placenta. The rate of fetal complications is directly related to the severity of the disease. Hell Lp syndrome. Hell Lp syndrome is a laboratory diagnosis for a variant of severe preeclampsia that is characterized by hemolysis. Elevated liver enzymes (EL) and low platelets (LP). ACOG. Blah blah blah. Okay. To have a diagnosis of Hell Lp syndrome, the platelet count must be less than 100,000 mm³, and the liver enzyme levels, aspartate aminotransferase or AST and alanine aminotransferase ALT, must be elevated. So low platelet and high AST and ALT. A unique form of coagulopathy, not DIC, occurs with Hell Lp syndrome. The platelet count is low, but coagulation factor assays, prothrombin time PT, partial thromboplastin time PTT, and bleeding time remain normal. In some instances, hemolysis does not occur, and the condition is termed ELLP. HELLP syndrome appears in approximately 20% of women with severe preeclampsia. Most commonly, HELLP syndrome is seen in older Caucasian multiparous women. About 90% of women report a history of malaise for several days. Many women, 65%, experience epigastric or right upper quadrant abdominal pain. possibly related to hepatic ischemia, and approximately half develop nausea and vomiting. Many women with Agl Lp syndrome may not have signs and symptoms of severe preeclampsia. Many are normotensive and have no proteinuria. As a result, women with Agl Lp syndrome are often misdiagnosed with a variety of other medical or surgical disorders. Recognition of the clinical and laboratory findings associated with Agl Lp syndrome is important if early aggressive therapy is to be initiated to prevent maternal and neonatal death. Complications reported with Agl Lp syndrome include renal failure, pulmonary edema, ruptured liver hematoma, DIC, and abrupto placentae. Nursing care management. Hypertensive disorders of pregnancy can occur without warning or with the gradual development of symptoms. See nursing process box. The best prevention methods include early neonatal care for identification of women at risk and early detection of preeclampsia. The woman is assessed for risk factors at her first prenatal visit. Protocol for blood pressure management or measurement. We don't need to do that. Okay, so accurate and consistent BP assessment is important for establishing a baseline and monitoring subtle changes throughout the pregnancy. BP readings are affected by maternal position and measurement techniques. Consistency must be ensured. Normally, the diastolic BP drops an average of 10 mmHg below non-pregnant values by mid-gestation and then slowly reaches non-pregnant levels in the third trimester. Elevation of BP focuses on trends, not on a single reading. Box 14.5 presents recommendations for standardizing this procedure. All right, fine, I'll read it. Box 14.5, protocol for blood pressure measurement. Measure blood pressure in the same arm with the woman in the same position each time, e.g. seated or in a 30-degree tilt on her left side. After positioning, allow the woman 5 minutes of quiet rest before blood pressure measurement is to encourage relaxation. If the woman is seated, her arm should be resting on the surface at the level of her heart. If the woman is in a lateral position, the lower arm should be positioned so the woman is not lying on the arm, and the blood pressure is then taken in the dependent arm. This more closely approximates the arterial pressure, whereas using the arm of the opposite side falsely reduces the measurement. Use the proper size cuff. Cuff should cover 80% of the upper arm. Okay, in women who have an upper arm too large for a standard size cuffs too short, a more accurate measure is obtained by taking the blood pressure with the cuff placed on the forearm and recording Korotkoff phase 5 at the radial artery. Okay, maintain a slow, steady deflation rate. Take the average of 2 readings 6 hours apart to minimize recorded blood pressure variations across time. Use Korotkoff phase 5 disappearance of sound for recording the diastolic value. Some sources recommend recording both phase 4, the muffled sound, and phase 5. Use accurate equipment. If interchanging manual and electronic devices, use caution in interpreting different blood pressure values. Okay, that was nothing too illuminating, but whatever. Back to the text. Observation of edema is, in addition to hypertension, warrants additional investigation, although there is universal agreement that edema should not be considered in the diagnosis of preeclampsia. Edema is assessed for a distribution, degree, and pitting. It may be described as dependent or pitting. Dependent edema is edema of the lowest or most dependent parts of the body, where hydrostatic pressure is greatest. Many normotensive pregnant women have dependent edema. If a pregnant woman is ambulatory, this edema may first be evident in the feet and ankles. If the woman is confined to bed, the edema is more likely to occur in the sacral region. Pitting edema is edema that leaves a small depression or pit after finger pressure is applied to the swollen area. The pit caused by movement of fluid away from the point of pressure to adjacent tissues normally disappears within 10 to 30 seconds. Although the amount of edema is difficult to quantify, the method shown in Figure 14.4 may be used to record relative degrees of edema formation. Although it is not a routine assessment during the prenatal period, evaluation of the fundus of the eye yields valuable data. Fundus of the eye. An initial baseline finding of normal eye grounds assists in differentiating a pre-existing from a new disease process. Deep tendon reflexes, or DTRs, are evaluated as a baseline and to detect any changes. The biceps and patellar reflexes and ankle clonus are assessed and the findings recorded, Figure 14.5. The evaluation of DTRs is especially important if the woman is being treated with magnesium sulfate. Deep tendon reflexes. Absence of DTRs may be an indication of impending magnesium toxicity. To elicit the biceps reflex, a downward blow is struck over the thumb, which is placed over the bicep tendon. Normal response is flexion of the arm at the elbow, described as a 2+ response. The Patella Reflex is elicited with the woman's legs hanging freely over the end of the examining table, or the woman lying on her side with the knee slightly flexed. A blow with the percussion hammer is dealt directly to the patellar tendon inferior to the patella. Normal response is the extension of the or kicking of the leg, which is recorded as 2+. To assess for hyperactive reflexes or clonus at the ankle joints, the examiner supports the legs with the knee flexed with one hand. The examiner sharply dorsiflexes the foot, maintaining the position for a moment, and then releases the foot. Normal or negative clonus response is elicited when no oscillation or jerk is held. Is held in dorsiflexion. When the foot is released, no oscillations are seen as the foot drops to the plantar flex position. Abnormal or positive clonus responses recognized by rhythmic oscillations by one or more beats felt when the foot is in dorsiflexion and seen as the foot drops to the plantar flex position. Signs and symptoms of progression to mild to severe preeclampsia, such as headaches, epigastric pain, and visual disturbances, are noted. The signs of mild versus severe preeclampsia are summarized in Table 14.2. Uteroplacental perfusion can be decreased in women with preeclampsia. Biophysical monitoring, such as non-stress testing, NST, contraction stress testing, CST, and biophysical profile, BPP, and serial ultrasonography is used to assess fetal status. The fetal heart rate, FHR, is assessed for baseline rate, variability, and presence of accelerations. Abnormal baseline rate, decreased or absent variability, or late decelerations are indications of fetal intolerance to the intrauterine environment. Since the woman with preeclampsia is at risk for abruptio placentae, it is important to assess uterine tone and tenderness in the presence of vaginal bleeding. Doppler flow velocimetry studies can be used to evaluate uteroplacental perfusion. Nursing alert: uterine tenderness in the presence of increasing tone may be the earliest finding of an abruption. Idiopathic preterm contractions also may be an early sign. So, now mild preeclampsia and home care. If the woman has mild preeclampsia, BP is stable, urine protein is less than 300 mg, and 24-hour collection, and there are no subjective complaints, she may be managed at home. The maternal fetal condition should be assessed 2 or 3 times per week. Many agencies are able to provide this assessment in the home, depending on the woman's insurance coverage. If home nursing is not possible, the woman may be asked to perform self-assessment daily, including weight, urine dipstick, protein determinations, and BP measurement and fetal movement counting. She will be instructed to report immediately any subjective symptoms to her primary health care provider and to return to the high-risk clinic or physician's office for all appointments as scheduled. The fetal condition is closely monitored to allow additional time for fetal growth and maturation, and evaluation of fetal growth by ultrasound should be obtained at a diagnosis and repeated every 3 weeks. Fetal movements are counted daily. Other fetal assessments tests include an NST once or twice a week and a BPP as needed. Fetal jeopardy, as evidenced by inappropriate growth or abnormal testing, necessitates immediate delivery. Activity restriction. Bed rest in the lateral recumbent position is a traditional therapy for preeclampsia and may improve uteral placental blood flow. Complete bed rest has been shown to be beneficial in decreasing BP and promoting diuresis. There is no evidence that bed rest improves pregnancy outcomes. Adverse physiologic outcomes related to bed rest include cardiovascular deconditioning, diuresis with accompanying fluid, electrolyte and weight loss, muscle atrophy, and psychologic stress. These changes begin on the first day of bed rest and continue for the duration of therapy. Thus, modified bed rest with bathroom privileges may be ordered to help decrease negative effects. Women with mild preeclampsia feel reasonably well, thus boredom from the restriction is common. Diversionary activities, visits from friends, telephone conversations, and creation of a comfortable and convenient environment are ways to cope with the boredom. Gentle exercise, e.g. range of motion, stretching, Kegel exercises, and pelvic tilts is important in maintaining muscle tone, blood flow, regularity of bowel function, and a sense of well-being. Relaxation techniques can help reduce stress associated with the high-risk condition and prepare the woman for labor and the birth. Diet and fluid recommendations are much the same as for healthy pregnant women. Diets high in protein and low in salt have been suggested to prevent preeclampsia. However, the efficacy of this has not been proven. The exception may be the women in chronic hypertension that had been successfully controlled with a low-salt diet before the pregnancy. Adequate fluid intakes help maintain optimum fluid volume and aids in renal perfusion and bowel function. Successful home care requires that the woman be well educated about preeclampsia and motivated to help to follow the plan of care. All teaching should include the woman and her family, and time must be allowed for assimilation of information, questions, and concerns. The woman's knowledge base is directly associated with her compliance with the prescribed treatment program. Methods for enhancing learning include visual aids, videotapes, handouts, and demonstrations with return demonstrations. Furthermore, the effects of illness, language, age, culture, beliefs, and support systems must be considered. Severe preeclampsia, or Hell Lp syndrome, hospital care. The woman with severe preeclampsia, or Hell Lp syndrome, should receive appropriate management in a tertiary care center. The woman may be admitted to an antepartum or a labor and birth unit, depending on the hospital. If the woman's condition is serious, she may be placed in an obstetric critical care unit or a medical intensive care unit for hemodynamic monitoring. If severe preeclampsia is diagnosed at less than 32 weeks, an initial observation period and conservative management may be attempted with a gestational age of 32 to 36 weeks. Labor is usually induced. Vaginal birth is considered safer than cesarean birth and should be attempted unless there are indications for cesarean birth, such as an unfavorable or effaced and undilated cervix. In pregnancies of less than 34 weeks, antenatal corticosteroids may be given to promote fetal lung maturation. If the birth can be delayed for 48 hours, steroids such as betamethasone, 12 milligrams intramuscular, 24 hours apart, may be given to the woman. Recognition of the clinical and laboratory findings of severe preeclampsia, or Hell Lp syndrome, is important to prevent maternal and perinatal mortality. The woman with severe preeclampsia, or Hell Lp syndrome, has multiple problems, and nursing care must focus on both the mother and the fetus. Maternal and fetal surveillance, patient education regarding the disease process, and the supportive measures directed toward the woman and her family are initiated. Assessments include review of the central nervous, cardiovascular, pulmonary, and renal systems. Weight is measured on admission and usually at the same time every day thereafter. Breath sounds are oscillated, and for crackles or diminished breath sounds, which may indicate pulmonary edema, an indwelling urinary catheter may be inserted to measure urinary output. Hemoglobin oxygen saturation can be assessed with a pulse oximeter catheter. Baseline laboratory assessments include metabolic studies for liver enzyme AST, ALT, lactate dehydrogenase, or LDH determination, complete blood count CBC with platelets, coagulation profile to assess for DIC, and electrolyte studies to establish renal functioning. Weight should be measured on admission and every day thereafter. An indwelling urinary catheter facilitates monitoring of renal function and effectiveness of therapy. However, the risk of urinary tract infection should be considered in the stable antepartum woman. If appropriate vaginal examination may be done to check for cervical. If appropriate vaginal examination may be done to check for cervical changes, abdominal palpations. Palpation establishes uterine tonicity and fetal size, activity, and position. Assessments of fetal well-being, e.g. NST and BPP, are ordered because of the potential for hypoxia related to uteroplacental insufficiency. Electronic monitoring to determine fetal status is initiated at least once a day. The nurse's skill in implementing the techniques described here can be reassuring to the woman and her family. The woman's room should be close to staff and emergency drugs, supplies, and equipment. Seizure precautions are taken because of the risk of thromboembolism. For the woman on bed rest, she may wear TED hose and SCD boots while in bed. Antepartum nursing care of the woman with severe preeclampsia or Agl Lp syndrome involves continuous maternal and fetal assessments as labor progresses, invasive hemodynamic monitoring with pulmonary artery catheter, a Swan-Ganz catheter, may be required for accurate intravascular fluid volume measurement in the presence of pulmonary edema or acute renal failure. Magnesium sulfate. One of the important goals of care for the woman with preeclampsia is prevention or control of convulsions. Magnesium sulfate is the drug of choice in the prevention and treatment of convulsions caused by preeclampsia or eclampsia. It is administered as a secondary infusion or piggyback to the main intravenous line by volumetric infusion pump. An initial loading dose of 4 to 6 grams diluted in at least 100 milliliters of IV fluid per protocol or physician's orders, infused over 15 to 30 minutes. This dose is followed by a maintenance dosage of magnesium sulfate diluted in an IV solution per physician's order, e.g. 40 grams of magnesium sulfate in 1,000 milliliters of lactated Ringer solution and administered by an infusion pump at 2 grams per hour. This dosage should maintain a therapeutic serum magnesium level of 4 to 7.5 millicube per liter or 5 to 7 milligrams per deciliter. No data exists to support the routine drawing of serial serum magnesium levels, although levels are often checked daily. After the loading dose, there may be a transient lowering of the arterial BP secondary to relaxation of smooth muscle. Nursing alert. The woman's BP, pulse, and respiratory status should be monitored closely while the loading dose is administered intravenously and every 15 to 30 minutes at other times, depending on the stability of the woman's condition. Magnesium sulfate is rarely given intramuscularly because the absorption rate cannot be controlled. Injections are painful and tissue necrosis can occur. The IM route may be used with some women who are being transported to a tertiary care center. The IM dose is 4 to 5 grams given in each buttock for a total of 10 grams. 1% procaine may be ordered to be added to the solution to reduce injection pain and can be repeated at 4-hour intervals. Z-track technique should be used for the deep IM injection, followed by gentle massage at the site. So what? You're not supposed to massage it? Whatever. Magnesium sulfate interferes with the release of acetylcholine in the synapses, decreasing neuromuscular irritability, depressing cardiac conduction, and decreasing central nervous system irritability. Because magnesium circulates free and unbound to protein and is excreted in the urine, accurate readings of maternal urine output must be maintained. Diuresis within 24 to 48 hours is an excellent prognostic sign. It is considered evidence that the perfusion of the kidneys has improved as a result of the relaxation of the arteriolar spasm. With improved perfusion, fluid moves from the interstitial spaces to the intravascular bed and edema is reduced. Diuresis results in weight loss. Although diuresis generally indicates improvement in the presence of worsening clinical signs that may indicate impending renal failure. As renal function declines and serum creatinine levels rise, renal filtration is compromised. The woman can excrete large volumes of urine greater than 200 milliliters per hour, but does not excrete magnesium sulfate. Because magnesium sulfate is a CNS depressant, the nurse assesses the signs and symptoms of magnesium toxicity. Serum magnesium levels are obtained on the basis of the woman's response, and if any signs of toxicity are present. Early symptoms of toxicity include decreased DTRs, nausea, a feeling of warmth, flushing, muscle weakness, decreased reflexes, and slurred speech. Nursing alert: loss of patellar reflexes, respiratory and muscular depression, oliguria, and decreased level of consciousness are signs of magnesium toxicity. If magnesium toxicity is suspected, the infusion should be discontinued immediately. Calcium gluconate, the antidote for magnesium sulfate, may be ordered 10 milliliters of a 10% solution or 1 gram and given by slow IV push, usually by the physician, over at least 3 minutes to avoid undesirable reactions such as dysrhythmias, bradycardia, and ventral fibrillation. Magnesium sulfate does not seem to affect FHR variability in a healthy term fetus. Neonatal serum magnesium levels approximate those of the mother. Doses of magnesium sulfate that prevent maternal seizures have been determined to be safe for the fetus. Toxic levels in the newborn can cause depressed respirations and hyporeflexia at birth. It is important that the neonatal team attend the birth to provide resuscitation measures as needed. In a 2-year follow-up study, magnesium administration was not found to result in an excess of disability or death in mothers. At the 18th month follow-up, magnesium administration was not associated with a difference in disability or death in infants who had in utero exposure to magnesium sulfate when compared with infants who were exposed to a placebo. Nursing alert. Because magnesium sulfate is also a tocolytic agent, its use can increase the duration of labor. The labor of a woman with preeclampsia receiving magnesium sulfate may need augmentation with oxytocin. The amount of oxytocin needed to stimulate labor may be more than that needed for a woman who is not receiving magnesium sulfate. Control of blood pressure. Antihypertensive medications may be ordered to lower the diastolic BP. Initiation of antihypertensive therapy reduces maternal morbidity and the mortality rates associated with left ventricular failure and cerebral hemorrhage. Because a degree of maternal hypertension is necessary to maintain utero-placental perfusion, antihypertensive therapy must be decreased. The arterial pressure too much. Antihypertensive therapy must not decrease the arterial pressure too much or too rapidly. Therefore, the target range for diastolic pressure is less than 110 mmHg and the systolic pressure less than 160 mmHg. IV hydralazine remains the antihypertensive agent of choice for the treatment of hypertension. Labetalol hydrochloride and nifedipine, verapamil, and oral methyl-dopa are also used. The choice of agent used depends on the woman's response and physician preference. Table 14.4 compares antihypertensive agents used to treat hypertension in pregnancy. Nursing alert. When administering antihypertensive therapy, the nurse must remember that the drug effects depend on intravascular volume. Because preeclampsia is associated with contracted intravascular volume, initial doses should be given with caution and maternal response monitored closely. Not quite sure what that meant. Eclampsia. Eclampsia is usually preceded by various premonitory symptoms and signs, including headache, severe epigastric pain, and hyperreflexia. However, convulsions can appear suddenly and without warning in a seemingly stable woman and with only minimum BP elevations. Increased hypertension and tonic contractions of all body muscles, seen as arms flexed, clenched, hands clenched, legs inverted, precede the convulsions. During this stage, muscles alternately relax and contract, respirations are halted and then begin again with long, deep stertorous inhalations, hypotension, and then coma follow. Nystagmus and muscular twitching persist for a time. Disorientation and amnesia cloud the immediate recovery. Seizures may reoccur within minutes of the first convulsion, or the woman may never have another. During the convulsion, the pregnant woman and fetus are not receiving oxygen, thus eclamptic seizures produce a marked metabolic insult to both the woman and the fetus. Immediate care. The immediate goal of care during a convulsion is to ensure a patent airway. See emergency box. Time, duration, and a description of the convulsions are recorded, and any urinary or fecal incontinence is noted. If possible, the fetus is monitored for adverse effects. However, this task should not take precedence over other stabilizing care measures. Transient fetal bradycardia and decreased FHR variability are common. A rapid assessment of uterine activity, cervical status, and fetal status is performed after a convulsion. During the convulsion, membranes can rupture and the cervix can dilate because the uterus becomes hypercontractile and hypertonic. Birth may be imminent. If birth is not imminent, once a woman's seizure activity and BP are controlled, a decision should be made regarding whether birth should take place. Since delivery is the definitive cure for the disease, the more serious the condition of the woman, the greater the need to proceed to the birth following the cessation of seizure activity. The means of birth, i.e. induction of labor versus cesarean birth, depends on maternal and fetal condition, fetal gestational age, presence of labor, and the cervical Bishop score. If fetal lungs are not mature and the birth can be delayed for 48 hours, steroids such as betamethasone can be given. If the woman has been incontinent of urine and stool, or the membranes have ruptured during the convulsion, she will need assistance with hygiene and change of gown. Oral care with a soft toothbrush may be of comfort. Nursing alert. Immediately after a seizure, the woman may be very confused and can be combative. Pad the side rails to prevent injury and maintain a quiet, darkened environment. It may take several hours for the woman to regain her usual level of mental functioning. She should not be left alone. Provide emotional support to the family and discuss with them the management, its rationale, and the woman's progress. Laboratory tests are ordered to assess for Agl Lp syndrome. Blood is typed and cross-matched for administration of impacted red blood cells as needed. The eclamptic woman is at high risk for abruptio placentae, which accompanying hemorrhage and shock. Other tests include determination of electrolyte levels, liver function, and a complete hemogram and clotting profile, including platelet count and fibrin split product levels to assess for DIC. Aspiration is a leading cause of maternal morbidity and mortality after an eclamptic seizure. After initial stabilization and airway management, the nurse should anticipate orders for a chest X-ray film and possibly arterial blood gases to determine whether aspiration occurred. Postpartum nursing care. After birth, the symptoms of preeclampsia or eclampsia resolve quickly, usually within 48 hours. Resolution of the disease process is manifested by diuresis, which usually occurs within 24 hours after the birth. The hematopoietic and hepatic complications of Agl Lp syndrome may persist longer. Usually an abrupt disease and decrease in platelet count occurs with a concomitant increase in LDH and AST levels after a trend toward normalization of values has begun. Generally, the laboratory abnormalities seen with Agl Lp syndrome resolve in 72 to 96 hours. The nursing care of the woman with hypertensive disease differs in a number of respects from that required in a normal postpartum period. These variations in the nursing process are described in the following paragraphs. The woman will need careful assessment of her vital tone and lochia flow throughout the postpartum period. The magnesium sulfate infusion is continued 12 to 24 hours for seizure prophylaxis. Even if no convulsions occurred before the birth, they may occur during the postpartum period. The same assessment continues until the medication is discontinued. Nursing alert! The woman is at risk for a boggy uterus and a large lochia flow as a result of the tocolytic effects of the magnesium sulfate therapy. Uterine tone and lochial flow must be monitored closely. The preeclamptic woman is usually concentrated and unable to tolerate excessive postpartum blood loss. Oxytocin or prostaglandin products are used to control bleeding. Ergo products, e.g. ergonovine or ergotrate and that's ergo, not ergo, and methyl ergonovine or methergine are contraindicated because they increase BP. Okay, so no ergo products, please. The woman is asked to report symptoms such as headaches and blurred vision. The nurse assesses affect, level of consciousness, BP, pulse, and respiratory status before an analgesic is given for headache. Magnesium sulfate potentiates the action for narcotics, CNS depressants, and calcium channel blockers. These medications must be administered with caution. The woman may need to continue antihypertensive medication if her diastolic BP exceeds 100 mmHg at discharge. Postpartum recovery may be prolonged as a result of the physiologic consequences of prolonged bed rest. The nurse should accompany the woman when she ambulates after prolonged bed rest and assess for weakness, dizziness, shortness of breath, and muscle soreness. The woman will also need reassurance that the physiologic effects of bed rest will reverse over time and when she resumes normal activity. The woman's and family's response to labor and birth in the newborn are monitored. Interactions and involvement in the care of the newborn are encouraged as much as the woman and her family desire. If the preeclampsia was severe, the infant may be premature and in a special care nursery. The woman and her family may be worried about the infant's survival, and the day-to-day fluctuations in the infant's status can be emotionally draining. In addition, the woman and her family need opportunities to discuss their emotional response to the complications. The nurse provides information concerning the prognosis. Preeclampsia and eclampsia do not necessarily recur in subsequent pregnancies. Recurrence rate is approximately 30%, but prenatal care is essential for assessment and early intervention. If the outcome for the mother or baby is unfavorable, the family is assisted in coping with loss and grief. Chronic hypertension. Chronic hypertension occurs in 5% of pregnant women. Chronic hypertension in pregnancy is associated with increased incidence of abruptio placentae, superimposed preeclampsia, and increased perinatal mortality. Fetal effects include fetal growth restriction in small for gestational age infants and fetal death. Women with chronic hypertension ideally should be screened before conception or at the first prenatal visit. Medications that could have adverse effects on the fetus should be discussed and can be discontinued or changed to another medication. Because of the antihypertensive effects of pregnancy, the antihypertensive medication may be discontinued or changed to another medication. Antihypertensive medications are instituted when the BP increases with gestational age, especially after 28 weeks. Based on the history and Based on the history and physical findings, women with chronic hypertension are identified as either at high or low risk for pregnancy complications. Women who are high risk are usually managed with antihypertensive therapy and frequent assessments of maternal and fetal well-being. The goal of treatment is to maintain a BP below 150 to 160 Hg systolic and 100 to 110 Hg diastolic. Methyl-dopa or Adalimumab is the drug of choice for treating chronic hypertension in pregnancy. If methyl-dopa is ineffective in reducing BP, beta blockers or calcium channel blockers can be used. The treatment of low-risk women is controversial. Evidence has not shown improvement in maternal or fetal outcome or decreased risk of developing superimposed preeclampsia with treatment. Lifestyle changes may be necessary, e.g. limiting sodium in the diet, limiting exercise during pregnancy, not smoking or using alcohol, limiting caffeine, and losing weight in the preconception period if overweight. The woman should be taught how to monitor her BP and count fetal movements, and the importance of bed rest. The time of birth is individualized, but a woman at low risk can usually wait until her cervix is favorable for induction at 37 weeks for gestation. The woman at high risk is followed closely, and the method and timing of the birth depends on maternal and fetal status. After giving birth, women with chronic hypertension, especially if at high risk, should be monitored for signs of complications such as renal failure, pulmonary edema, heart failure, and encephalopathy. Because all antihypertensive drugs are found in breast milk, the drugs of choice are methyl-dopa or hydralazine. Short-term studies have not found any adverse effects on infants, but no long-term human studies have examined the drug effects on infants. The risks and benefits of contraception should be with the mother and her family before discharge from the hospital. Provided that the woman is compliant and there is close follow-up, she can use all types of contraception. The risks of oral contraception must be discussed, including the risk of thromboembolic events. Estrogen has a negative effect on some clotting factors, angiotensinogen, total cholesterol, and triglycerides. Progesterone has a negative effect on lipoproteins and insulin resistance. Okay, and that was preeclampsia, 54 minutes.